dear member and guest. My name is Christelle Gualguen from Nantes in pediatric departments, and I'm very happy to present to you today's impact of procalcitonin-based algorithm on antibiotics exposure in neonates. This is my conflict of interest disclosure. Early onset GBS incidence dramatically has decreased since the generalization of per-partum antibiotics prophylaxis in 19s. In a recent study in United States, we observed that GBS is still the most common pathogen in early onset neonatal infection, followed by E. coli. All-cause sepsis incidence is stable during this 10 years period, but GBS incidence decreased significantly during this 10 years. Early onset neonatal infection have become rare in term newborns. Now it seems necessary to change our perinatal antibiotics treatment practice because there is an unbalanced benefits risk with a risk of a treatment side effect. We need a new approach to avoid overdiagnosis and overtreatment. What is frightening in side effects is the risk of antibiotic resistance and also the risk of microbiota disturbance with future implication on neonate, child, and adult health. That's why various tools are now available to try to stratify the risk of neonatal infection. This is the American clinical algorithm that's proposed to decide what to do regarding signs of neonatal sepsis, but also maternal risk of infection. Early onset sepsis calculator has been published 15 years ago now and proposed also to stratify the risk of neonatal infection in term newborns regarding clinical presentation and also maternal risk factors. When using the early onset sepsis calculator, up to 4% of live births would be treated by antibiotics empirically. A lot of publications are now available on the impact of this calculator on practice in maternity wards. It appears as an effective way to limit antibiotics treatment and also to limit blood test. This is confirmed in a recent meta-analysis. Management guided by this calculator is associated with a significant reduction in empirical antibiotics versus conventional management and a relative risk of 56% in before-after implementation studies. However, safety data were limited. That's why we proposed a different approach, maybe complementary, based on an old biomarker that is procalcitonin. Procalcitonin has been described in newborns 20 years ago and is known to have a physiological peak in the first hours after birth that make his interpretation a little difficult for physicians. However, this biomarker has been used by Stocker et al. In Switzerland in a very nice study. And he proposed procalcitonin to guide the decision of duration of antibiotic therapy in neonates in a multicentric randomized controlled trial. And among a lot of newborns, 1,700 in 18 European centers, Stocker et al. Demonstrate that procalcitonin guide treatment duration was associated with a significantly decrease in the treatment duration. What we test in my team 15 years ago is to study the umbilical cord blood procalcitonin level in order to bypass the physiological peak already mentioned. And in this study, we observed a very interesting diagnostic value of PCT in term and preterm newborn with positive and also negative likelihood ratio, possibly promising. In this nomogram, you can see that the post-test probability was interesting in case of positive value of PCT. The cutoff was 0.6 nanogram per liter, but also the post-test probability was particularly interesting in case of negative value of the PCT. Following these first results, we decided to study the impact, the possible impact of an algorithm using a PCT cord value and combining clinical symptoms and also CRP to test the exposure to antibiotics. And we observed that such an algorithm could decrease the antibiotics and test very significantly in the neonatal population of newborn with risk factors of early onset neonatal infection. So we conducted a few years later the DIACART study about diagnostic performance comparison between procalcitonin-based versus French guidelines. This study was designed to test the impact of an antibiotic use in newborn with suspected early onset neonatal infection and was a stepwise cluster randomized trial. The aim of the study was to assess whether a procalcitonin-based algorithm can aid the pediatrician in antibiotic prescription and contribute to safely reduce neonatal exposure to antibiotic treatment. The main outcome was double with a non-inferiority early onset neonatal infection rate at day 6 after birth. Neonatal hospitalization in neonatal intensive care and death was considered, but we had also a superiority outcome with antibiotic exposition rate at day 6 after birth. Secondary outcome were invasive biological exams at day 5 and the rate of late onset neonatal infection 3 months after birth. This is the study designed in a stepwise. All the centers were randomized to the study and begin with the current practice and turn in the new PCT algorithm after randomization during all the study period. The PCT algorithm was the same than previously showed, with symptoms of infection with the value of PCT cord, umbilical blood, and the value of CRP. The whole combination was proposed to decide on a blood test, clinical surveillance in maternity, or antibiotics treatment. This is a flowchart of the study with more than 9,000 children included and randomized between the French current guidelines or the PCT-based algorithm. This is the demographic and the clinical characteristics of the newborns and their mothers included in the study. This is the first results with altogether 11 proven early onset neonatal infection among the 9,000 newborn included. The incidence is 1 birth with infection risk factor. The symptoms were not present in 3 infected newborns, and the symptoms were early in 5 of them, with respiratory distress or hemodynamic distress, and 3 newborns had late symptoms with respiratory distress. The evolution was good for all of them except 2 with sequelae, and no death was observed in this study. Regarding our main outcome, the mortality criterion was correct because we had a non-inferiority proven in this study in the intention to treat population, but also per protocol population. Regarding the second main outcome with the postnatal exposition to antibiotics, we observed a significant reduction of antibiotic exposition of 2% with a relative decrease of 64%. Biological examinations decreased too, with a significant decrease in blood sample and blood culture. We conclude that procalcitonin aid decision making was superior to standard care in reducing antibiotic therapy in neonates with suspected early onset neonatal sepsis, and non-inferiority for reinfection or death could not be shown due to the low occurrence of reinfection and absence of study-related deaths. In summary, PCT-based antibiotic stewardship in a neonate population vulnerable to both bacterial and antibiotic effects enable an individual risk stratification and optimization of antibiotic use. Thank you for your attention.
I want to thank Thermo Fisher for the invitation to participate in this symposium with Professor Carroll and Professor Grassley-Gren. It's an honor for me. My name is Elizabeth Esteban, and today I will talk to you about how do procalcitonin-aided protocols decrease antibiotic use in pediatric patients. These are my conflict of interest disclosure. And just to put in context, I work in Hospital St. John of God. It's located in Barcelona. It's a private non-profit institution dedicated to public service. And this is a pediatric and maternity university hospital. We work in the pediatric intensive care unit. It's a medical and surgical unit with 28 beds and more than 1,300 admissions per year. As you know, antimicrobial resistance is an emergency and is a major public health concern, and it's mandatory to fight against it. And how can I reduce antibiotics in the PICU? I can do many things. We can prescribe less antibiotics, we can stop treatments, we can de-escalate, and we can use shorter regimes. But sometimes it's difficult because many patients are severely ill, and sometimes the pediatric intensivists are concerned about the evolution of their patients. So in this point, the question is it safe for my patient? We are convinced that absolutely yes, if you use the correct tools. And if you assess continuously the clinical status of your patient, if you use biomarkers to help you, and if you use good antibiotic stewardship programs. There are a lot of previous studies that demonstrate the usefulness of procalcitonin to reduce the consumption of antibiotics. But today I will share with you our first-hand experience to reduce antibiotics in our PICU. One of the investigation lines of our team that is coordinated by Dr. Yolanda Jordan is focused on infections and the use of biomarkers. And today I will show you studies about the PCT-aided protocols to reduce the consumption of antibiotics in 3 clinical conditions: in nosocomial infections, in bronchiolitis, and after cardiovascular surgery. So the first experience that I will show you is a pre-running study, and is focused on nosocomial infection. The aim of this study was to analyze antibiotic stewardship practices in children with nosocomial infection after implementing a PCT-based decision protocol. It was a prospective study and would meet the patients from 1 month to 18 years with bacterial diagnosis of nosocomial infection. We compared 2 cohorts, the pre-implementation period and the post-implementation period. This is the algorithm that we implemented. And at your left, you have a clinical case to illustrate it, because it's a little bit difficult to understand, and we think that it could be easier to show you the algorithm. So if you have the suspicion of nosocomial infection, you have to start antibiotics in case of pediatric intensive care, broad-spectrum antibiotic. In this case, we have a 3-year-old boy. He's an oncologic patient with a catheter-related infection and signs and symptoms of sepsis. So at the admission, we started meropenem and vancomycin. If the bacterial infection is confirmed after a minimum of 48 hours, you have to check the clinical evolution of your patient. If there is a partial response with decrease in PCT, you can de-escalate the treatment according to the antibiogram. And in our case, we isolated Staphylococcus aureus in the blood culture, so we stopped meropenem and we continued with vancomycin. If the patient has a good response criteria, after a minimum of 7 days, you can stop antibiotics. In our case, after 7 days, the PCT clearly decreased, so we stopped antibiotic on day 7. And according to our protocol, a good response criteria includes clinical resolution and improvement in some analytical data, as well as the leukocyte count and a reduction of CRP, and a PCT decrease in more than 50% in comparison to the value at diagnosis of if you have PCT less than 0.5 nanograms per milliliter. By the other hand, if you have no response, you have to consider other infections, complications, and you have to change antibiotics, and sometimes you will have to escalate the treatment. We included a total of 96 patients, and we didn't find differences in clinical epidemiological data and neither in outcomes. The percentage of antibiotic stewardship increased clearly from the pre-implementation period to the post-implementation from 59% to 86%. And the total duration of antibiotic decreased in the second period, especially for the duration of the first antibiotic treatment that was always a broad-spectrum antibiotic. And we think that this is very important. So This PCT-aided protocol helped us to reduce the consumption of broad-spectrum antibiotic in patients with nosocomial infections. We move to bronchiolitis, and we want to show you two studies focused on bronchiolitis. The first study describes the use of PCT and CRP to diagnose invasive bacterial infection in patients with bronchiolitis. And it was a prospective and descriptive study across 7 years in our unit. We included 675 patients, and we compared patients with invasive bacterial infection and without bacterial infection. And as you can see, only 26% of the total of the sample suffered a bacterial infection. However, the percentage of antibiotic was very high in all groups, in the total, but also in those patients without bacterial infection. In this case, 74% of patients received antibiotic. In this slide, you can see at your left the evolution of the PCT and CRP values in the patients, depending on if they suffered sepsis, a pneumonia, a urinary tract infection, compared to those patients without bacterial infections, and was clearly higher. And this is the same in the CRP for sepsis, pneumonia, and urinary tract infections. And the area of the curve was better for PCT compared to CRP at admission at 24 hours and at 48 hours. And the best cutoff for PCT to diagnose invasive bacterial infection at admission in patients with bronchiolitis was 1.4 nanograms per milliliter. So PCT and CRP were useful to diagnose invasive bacterial infections in our patients with bronchiolitis, but PCT seemed to be more efficient than CRP to diagnose invasive bacterial infection, especially in patients with sepsis and pneumonia. And there is a high percentage of patients without invasive bacterial infections who receive antibiotics. So we think that there is clearly a room for improvement in this area in our unit. The second study that I will show you is very similar to the Prorani study in nosocomial infection. And the aim was to determine the effectiveness and safety of a PCT-aided protocol to decrease the consumption of antibiotic in patients with severe bronchiolitis. The design is the same than in the other, and we admitted patients with bronchiolitis and a suspected bacterial infection. And a PCT-aided protocol was established in 2014, and we compared two cohorts. And the pre-implementation period, we recruited 3,340 patients, and in the post-implementation, 366 patients. And at your right, you have the algorithm that we use. If you have a patient with severe bronchiolitis admitted to the PQ, and you suspect an infection, a bacterial infection, you have to check the clinical condition of your patient. If the patient has a bad general condition and just suspect sepsis, you have to start antibiotic independently on the biomarkers. If the bacterial infection is confirmed, you have to continue antibiotic according to your local protocol. And if the bacterial infection is non-confirmed, your PCT is less than 1 or less than 50% of the maximum value of the PCT, you can stop antibiotics after 3 or 5 days. By the other hand, if your patient has a good general condition and you suspect an infection but you don't suspect sepsis, you have two options. If the CRP is less than 70 milligrams per liter or PCT is less than 1 nanograms per milliliter, antibiotic is not recommended. And you have to continuously assess the condition of the clinical condition. And if CRP is higher than 70, but PCT is higher than 1, you have to start antibiotic treatment and you follow the left branch of this algorithm. We compared the two periods, and again, we didn't find differences in clinical data and neither in outcomes. And as you can see, comparing the two periods, the percentage of antibiotic was lower in the second period and changed from 88% to 72. And the antibiotic stewardship practice increased in the second period, and the total duration of treatment decreased more than 3 days after the implementation of the protocol. At your right, you have in this table the duration of the antibiotic treatment depending on the kind of infection, in sepsis, pneumonia, and urinary tract infections. And when we compare the two periods, you can see that the duration was clearly lower in the second period for each kind of infection. And no adverse outcomes were observed due to the implementation of this protocol. So this PCT-aided protocol led to a safe and general decrease in antibiotic use in patients with severe bronchiolitis in our unit. And the last study that we will present to you is focused on the effectiveness of PCT in decreasing the duration of antibiotic after cardiovascular surgery. These patients often receive antibiotics because they have signs and symptoms of inflammation after extracorporeal circulation that are difficult to distinguish from infection. The design was the same as the previous studies and was a prospective study, and we included patients under 18 years admitted after cardiovascular surgery. We implemented our PCT-aided protocol, and in the pre-implementation period, PCT was used to initiate antibiotic and not to de-escalate or to stop. And after the implementation of this protocol, we used PCT to initiate antibiotic and to de-escalate and to stop. We used a cutoff of 2 nanograms per milliliter in the first day and 4 in the second day because these were the best cutoffs to diagnose bacterial infection after cardiovascular surgery after a previous study performed in our unit, as you can see here. And this is the algorithm. If you suspect of a bacterial infection in your patient after cardiovascular surgery with an increase in PCT, you have to start empiric antibiotic. And you have to check the response. If there is a partial response with a decrease in PCT and a good clinical evolution, you have 2 options. If the culture is positive, you can stewardship according to the antibiogram. And if the culture is negative, but the patient has a good clinical evolution and the decrease in PCT is higher than 20% respect to the maximum value, you can stewardship. If your patient has a good response with positive culture, you complete the antibiotic treatment according to your protocol. And if the culture is negative, but there is a good clinical evolution, and the PCT decreases more than 50% respect to the maximum value, or your PCT is less than 0.5 nanograms per milliliter, you can stop antibiotics. By the other hand, if you start antibiotic in your patient and you see that PCT increases and there is a bad clinical evolution, you have to assume that there is no response and you have to check other infections, complications, and you have to change antibiotics. This is the evolution of the values of procalcitonin at admission for 24 hours, 48 and 72 hours after in patients with suspicion of infection and without. And there were differences, statistically significant differences at any time. In this case, we didn't find differences in clinical and epidemiological data and neither in outcomes, and we included a total of 2,026 patients. And as you can see, the option of no de-escalation was clearly lower in the second period, and the duration of the antibiotic treatment was lower in the second period after the implementation. And the antibiotic-free days in PQ and the antibiotic-free days in total increased clearly after the implementation of this protocol, and no adverse outcomes were found. To conclude, in our experience in pediatric intensive care, we think that PCT-aided protocols are useful to reduce the consumption of antibiotics. Because we limit the prescription of antibiotics, we de-escalate more and we stop antibiotics. And it has been safe without differences in outcomes, and no reinfections have been found. We always say that PCT is a good tool, but never substitutes a clinical evaluation of our patient that is mandatory. Here you have my email. You can contact me whenever you want, and I will be glad to answer your questions. Thank you very much for your attention.
Thank you to our speakers who I'd like to introduce this afternoon. First, Professor Christelle Gralagain, who is a professor of pediatrics at Nantes University. She specializes in infectious diseases in children and neonates with a focus on diagnostic markers and clinical decision rules. She's also chief of the emergency department and the pediatric department at Nantes University Hospital. I'd also like to present Dr. Elizabeth Esteban, who is a pediatric intensivist at Hospital St. John of God, Barcelona. She's chief of pediatric transport team and coordinator of the pediatric sepsis code in Catalonia. She specializes in pediatric sepsis and has published numerous research articles in the field. So to the audience, you can start submitting your questions, and some of you have already done that, which is in the Q&A on the right-hand side of the screen. And I'll read out the questions. So I'll start firstly just for Professor Gralagain, just to clarify that in your presentation on early onset neonatal infection, the definition is less than 72 hours. Is that correct?
Yes, that's correct.
Okay, so we'll take the first question, I think, is for you. And it says, how will your study results impact on clinical practice in France? Because you demonstrated superiority compared to current guidelines.
Thank you very much for this question. It's a very important point because we had to rewrite our French guidelines in the few next months, and we proposed to include PCT in as a possible way to stratify the risk of infection. So right now, this current recommendations do not mention the use of PCT, but the next one will.
Thank you very much. The next question, I think, is for Dr. Esteban. And it says, in the study on bronchiolitis, how did you define pneumonia in children who were not intubated?
Thank you for this question. In this study, most of pneumonias were diagnosed in patients that were intubated, but in those patients who were not intubated, we diagnosed the pneumonia with a combination of the X-ray, the ultrasound, and the values of the procalcitonin.
Thank you very much. Another question says, I think this is for Dr. Esteban. Based on your data, how would you recommend to use PCT versus CRP in case of suspected significant bacterial infection? In which cases or situations would you use either or both?
Okay, this is a key question. Very nice. This is not easy to answer, but in our practice, nowadays we use procalcitonin to help us to decide, to prescribe and also to de-escalate antibiotics. And we have a lower use of CRP because we have a better sensitivity and specificity for procalcitonin. and in all cases when we suspect a bacterial infection. For nosocomial infection and also for patient with bronchiolitis or sepsis. And this is our current practice.
Thank you very much. We have another question, I think this one for Professor Grell again. What is the response time to infection at or soon after birth? And I think here that refers to the relative differences in kinetics between PCT and CRP.
Yes, actually, in a preliminary study, we compared the diagnostic value of CRP and PCT on the umbilical blood cord. And as expected, the PCT value was superior to the CRP because of this kinetic. And altogether, those two biomarkers have the same diagnostic value. The only difference is that you have the information with the PCT 5 hours after the beginning of infection, and with the CRP you have to wait 24 hours before the increase of the biomarkers. So the information is the same, but with the PCT you've got the information very earlier.
Thank you very much. There's a related question, and that is, do you think that antibiotic stewardship in preterm babies is also possible with PCT?
Probably yes. There is an ongoing study in France with a randomized study among more than 50 centers of a neonatal intensive care unit. And we try to demonstrate the impact of PCT on the antibiotic duration. The only limit is the volume of the blood needed to the test. And this study is ongoing, and I hope we will be able to answer soon.
Thank you. I had a related question because in the data you showed, which were very nice data, thank you very much, you demonstrated that there was a low occurrence of non-inferiority, that is reinfection or death. And if you recall, that was the same finding in the NEOPIN study from Switzerland and the Netherlands. But one of the criticisms of the NEOPIN study was that they didn't include high-risk infants. Did you include high-risk infants in your study?
Yes, we did. The population was not the same. In the Jacquard study, the included newborns were only newborns with neonatal infection risk factors. The population is not the same, and that's why the incidence of infection is not the same.
Okay, thank you. So this question is for, I think, for both of you. It says, if you are asked by a colleague who is not using PCT yet, what would you say is the biggest benefit in neonatology and pediatrics?
In neonatology, on my mind, the best interest of the PCT is to reduce the antibiotics duration, not for the initiation of the treatment, but for the stop of the treatment.
Yeah, thank you. I would agree with that. Dr. Esteban?
Yes, thank you. I agree, Professor Gras-Legren. I think in pediatrics, we can use it to prescribe antibiotics, and we can use also to de-escalate. But the question is that we prefer this help to decide. I think there is another interesting question that could be related to this one. And I think one colleague asked us about the clinical status of the patient, of the assessment of the clinicals of the patient. And I think this is crucial. This is very important to know that we can't substitute the power of the clinical assessment of our patient with a biomarker, neither procalcitonin or CRP. This is my opinion. But I think that procalcitonin can help us, and it is safer for our patient.
Thank you very much. Another question for you, Dr. Esteban. Is it possible to de-escalate without biomarkers?
This question is really nice, and I think it could be like jumping without a net. I think that in the era of the patient safety, if we have this tool, we need to use it because it's safer for our patient. And we have to control the clinical status. And if we have another tool that can help us to decide, I think it's a better practice for our patients. I don't know if Professor Graslgren agree with it.
Yes, I agree with you, because if clinical indications and clinical symptoms would be enough, that would be done all the days. And what we observed today is that neonates and children generally are overexposed to antibiotics. So it's not enough to be clinical based, and we need some help, and maybe PCT help.
Thank you. Another question for you, Professor Greligan. Would you propose to use cord blood for early onset sepsis detection?
I just try to. Yes. Thank you for this question. I think it's a promising approach. We need to publish these new results and to discuss all together of the exact place of this approach. But that could be interesting, or maybe that would be interesting to combine the PCT value on the EOS calculator, and to improve the diagnostic value of the calculator.
Yeah, thank you very much. I think that's an important consideration, particularly where there are limited blood volumes. If one can use cord blood, then that potentially could be helpful. So there's another question here about, has there been any cost-benefit analysis between PCT and CRP? And I think that's for both of you.
At this time, I'm not sure that those studies have been done, but that would be very important, of course, to conduct such an approach, because at this time, the PCT is, of course, more expensive than the CRP.
Yes.
Thank you.
Yes, in addition, I want to say something, because I think that is really very important when you use biomarker, is to order and to monitor the PCT twice per day and at the acute phase of the illness, and later you can monitor once per day, or maybe every 2 days. If you have if you are conscious of the consumption of the procalcitonin or the CRP, and if you don't monitor continuously this biomarker, you have a better use of the money for your patient. And if you look at the reduction of the consumption of antibiotic, it's clearly better to use the biomarker, in my opinion.
Thank you very much. I mean, I should say, in answer to that, I think we all agree that the cost-benefit analysis is hugely important. And I will shamelessly promote one of our studies, which is called a batch trial, biomarker-guided antibiotic duration in hospitalized children, that is across the UK. And that one is it's not about antibiotic initiation, it's about antibiotic stopping. And so we're comparing standard care versus PCT-guided algorithm, and that includes a health economic analysis, because it's really important. Even if we show a clinical benefit, we need to be able to demonstrate that it's cost effective. So our study includes a health economics analysis as well as a qualitative component. Again, if you have a test, if doctors don't adhere to it, then there's no point having a test. So we'll be looking at both those aspects of the study. The study, like most things, is delayed because of COVID, but we hope that in the next 18 months, perhaps, we should conclude. We're about halfway. We've recruited about 1,000 out of 2,000, just over 1,000. So hopefully in the next year or so, we should be able to answer that question in children in hospital. So there's another question about, in the context of severe sepsis, PCT is sometimes high due to organ dysfunction and not due to infection. How do you use PCT in that situation?
Sorry, Professor Carol, could you repeat me, please?
So sorry. So it says, in the context of severe sepsis, PCT is sometimes high due to organ dysfunction, but not due to the infection itself. So how would you use PCT in that situation?
In case of severe sepsis or in septic shock, or in case of any inflammation condition, you could have high values of procalcitonin. And in our opinion, we manage it according to our algorithms. If we have a high PCT, we still continue with the antibiotic. And if we have a reduction, we decrease the antibiotic, or we de-escalate, or maybe we stop antibiotic.
Thank you very much. I think it's correct to say, Dr. Esteban, that you've also done some work on another biomarker, which may perhaps be more reflective of organ dysfunction, and that's mid-range proadrenomedullin, ADM. You have also measured that biomarker with respect to organ dysfunction. But anyway, that's not the subject of this seminar. Did you want to comment?
Yes, we use other biomarkers as prognostic biomarkers of the illness, and we have experience with proadrenomedullin in this kind of infections. Yes, we have some papers related to.
Thank you.
We think that is a good biomarker for prognosis.
Thank you. Professor Grell again, how often do you measure PCT in newborns with suspicion of infection?
By definition, when we test PCT in umbilical cord value, it's only possible in the few minutes after birth, and we did not test the PCT value after birth. But Martin Stoker do, and this study was very interesting to show how to manage the hours post birth. But in my experience, we only test the PCT umbilical cord at birth.
Thank you. I think this one is also for you, Professor Grell again. For early onset neonatal sepsis, according to the UK NICE guidelines, we have to wait for 36 hours to get blood culture results before stopping antibiotics. So this person says they're not sure how PCT could reduce antibiotics use in this group of infants.
Yes, that's right, and I hope that in the UK you succeed in stopping antibiotics as soon as 36 hours after birth. But in France, we are not able to do that, and a lot of clinicians are frightened and refuse to stop as soon as 36 hours after birth. So PCT value is an help to comfort the clinician in this decision. In my experience.
Thank you. There's a question. I think this might be for the manufacturer. Is there any difference in the lab values versus values in the point of care device?
at this time, I think that there is very few data on point of care PCT value, and studies are ongoing.
Yeah, thank you. So I also had a question for Dr. Esteban. So in your algorithm, you used a PCT reduction of more than 50% to define a good response. Why did you not use 70% or 80% as recommended in the manufacturer's guidance?
We had the consensus when we designed this algorithm, based it on previous experience and based it in the prorata trial. And this was our design. And in our experience, it's okay. And we have a good reduction of antibiotic. And that is most important, is that we don't have reinfections in our studies.
Thank you. So I think I cannot see any other questions, but I wonder, whilst we're waiting, if anybody has any questions, whether either Professor Gralligan or Dr. Esteban, you would like to add anything in our concluding 10 minutes.
If you want, I can start. To conclude, the same message that during the speech, the procalcitonin is a good tool and can help us to decide to prescribe antibiotic and to reduce. I think that it's very, very important today to reduce the consumption of antibiotic, especially for broad spectrum antibiotic. I think this is the key. Because the antimicrobial resistance is a major concern, and we can reduce not also the days of antibiotic, but also the cost of this antibiotic and also the toxicity related to the antibiotic therapy. But because sometimes we don't take into account that this antibiotic can have a significant toxicity for our patients, for example, for vancomycin or others. Thank you, Professor Carroll.
Thank you.
Thank you, Professor Anitten. For the conclusion, I would suggest to insist on the value of PCT that is interesting only when combined with clinical symptoms and with the evolution. So it is only an help, and the brain of the clinicians are the most important part of the decision, and PCT could be useful when with a good utilization and an utilization evidence-based when more studies will be available.
Thank you. One question has just come in. Any studies on PCT been done in febrile neutropenia, oncology patients?
Yes.
Yes, there are several studies in oncologic patients, and sometimes the evolution of procalcitonin levels are different than in patients without a neutropenia or without that are not immunocompromised. But this is useful also, and you can use procalcitonin in this population of patients.
Thank you. And in the last few minutes, Professor Gralligan, I don't know if you would like to talk briefly about your ongoing trial about PCT in antibiotic initiation in the emergency department in France, because that is the difficult bit, the stopping. Dr. Esteban said for limiting prescription, for de-escalating, and for stopping. I think de-escalating and stopping is easy, but to limit this initiation is very difficult. What is your view about that, Professor Gralligan?
Yes, I totally agree with you. It's a very clinical. The initiation of the treatment is a clinical part of the treatment, the PCT can help to reduce the duration of the treatment, but the initiation will be decided by the symptoms and the risk analysis. That could be help with antibiotic stewardship and guidelines and national or international guidelines, but the PCT cannot help to initiate or not. Only can help on the stop decision and the treatment duration. That is my point of view.
Thank you very much.
Excuse me, if you let me add one comment just. Yes, of course, I agree. I am talking about initiate our antibiotic in the right side of my algorithm of bronchiolitis. Of course, if you suspect sepsis in any patient, independently of the values of your biomarkers, you have to initiate antibiotic and later you can stop it.
Thank you. Well, thank you very much. I can't see any other questions, but I'd like to thank firstly our excellent speakers for their very enlightening talk and for demonstrating such powerful data on the potential of PCT to improve antimicrobial stewardship in neonates, including preterm neonates, and also in children with bronchiolitis, with nosocomial infection and after cardiac surgery. I thought they were really enlightening talks. And I'd also like to thank the manufacturers for sponsoring the study. And if there are no other questions, then I think we can wrap up this session. Thank you very much for listening, and thank you for your participation.
Thank you, Professor.
Thank you very much.